Hey, good morning, everyone. I'm your host, Vic Sinise, and welcome to UroNurse. We come to you every Saturday at 9 a.m. Central Time. If you're watching us live, you can catch us on YouTube, LinkedIn, Facebook Live, or X. And of course, we're always coming to you also on StreamYard, but you have to register for that one. Be sure to subscribe, follow. We're doing great with all those things with you guys too. So glad to have you on board. First time checking us out, great. Check us out at our website too at uronurse.com. Best place to go to learn about past episodes, visit our other great podcasts, and visit our sponsors. Also, best place to find all those past episodes, all 146 of them. This is episode 147. Whoo-wee, a lot of episodes. Hey, we also know you like to listen to us in your car, so no problemo with that. Check out our audio podcast. Comes out shortly after this show, and you can subscribe through Apple Podcasts, Spotify, iHeart, Amazon Music, or YouTube Music, and they'll automatically deliver it to your box when it's available. So do that, please. Hey, this week we're going to have a special episode. We're going to be doing a half credit CE show. It's going to be on the overview of Clostridium difficile. I think this is a good one to kind of get a little reminder because it pops up now and then, and maybe we don't always remember what causes it, what we need to do to treat for it, how we test for it. So we're going to do a covered, and we're going to give you a half a credit on that one. Now, we won't have any experts joining us, and I won't be doing any Q&A, even though this is only a half-hour show. This is one of the few ones I'm actually pre-recording. And the reason for that is I've got tickets today to go see the Indiana Fever. Now, I live in Indiana, and I'm a big Caitlin Clark fan. So WNBA, Indiana Fever, I got tickets to the game, so we're going to go see it. Couldn't be in two places at once, though. I got to drive to Indianapolis for the game. So anyway, enjoy this episode.
Hello, my name is Melissa Fortin. I'm a nurse practitioner at the Norton Infectious Diseases Institute, and today I'm going to be discussing Clostridium difficile, or C. diff. Funding for this presentation was provided by the Kentucky Department for Public Health. I have no financial disclosures. By the end of the presentation, I would expect you to be able to describe C. difficile infection symptoms and risks, review interventions to decrease the risk of C. difficile infection, and list the roles of environmental cleaning to prevent C. diff infection and spread. So what is C. diff? It's a gram-positive anaerobic bacillus that is able to form spores. These spores are able to survive in the environment and can be found in soil, air, water, and on surfaces. C. diff is a common cause of antibiotic-associated diarrhea. Now, it's important to note that C. diff can be part of the normal gut flora for healthy people. About 5% of adults are colonized with C. diff, meaning the C. diff is in their intestines but not causing any health problems. For hospitalized patients, that number increases. Up to 70% of babies carry C. diff in their gut. So why aren't we worried about all these babies with C. diff? That's because only some strains of C. diff produce toxins. We call those strains toxigenic C. diff. When C. diff becomes active and starts growing, it causes damage to the epithelium, or lining of the bowel walls. Between that damage and the immune system's response, the patient develops symptoms. To be clear, for the remainder of the presentation, when I talk about C. diff and infections, I am referring to toxigenic C. diff. C. diff isn't able to survive outside of the body, so it produces spores, which have a really tough coating on the outside of the bacteria that makes it really hard to kill and allows the bacteria to survive in a variety of environments. I think of bacteria as hibernating while in spore form. Spores are able to survive extreme temperatures and acidity. For example, they can survive the highly acidic upper GI system in humans. The spores can be present in the environment and inadvertently be ingested by a person. The spores then survive the stomach and make it to the intestines. There, if the conditions are favorable, the coating will dissolve and the C. diff bacteria will germinate. CDI, or C. diff infection, affects about 500,000 people per year in the United States and accounts for 15 to 25% of all episodes of antibiotic-associated diarrhea. Even with appropriate treatment, 1 out of every 6 people will get another C. diff infection in 2 to 8 weeks. For those over the age of 65, 1 out of 11 will die within 1 month of diagnosis. C. diff infections cause over 29,000 deaths each year in the U.S. Toxigenic C. diff is resistant to a wide range of antibiotics and causes a significant economic burden. And C. diff infections are categorized as an urgent threat by the CDC. Risk factors for developing a C. diff infection are age, being over 65 will increase your risk, being immunocompromised, having any previous C. diff infections, recent hospitalization, or if you've recently taken a course of antibiotics. You're 7 to 10 times more likely to get C. diff while taking antibiotics and for the 1 month after you finish taking an antibiotic. While any antibiotic can increase the risk of development of C. diff infection, there are certain antibiotics that are more likely to cause an infection than others, namely clindamycin, fluoroquinolones, and 3rd and 4th generation cephalosporins. Because of that, it's important for prescribers to avoid, if possible, giving certain antibiotics for those with a history or a high risk of developing C. diff infection, and to use the shortest effective antibiotic duration. Prescribers should also reassess antibiotic therapy based on the patient's condition and test results. It's also important to verify any reported antibiotic allergy. As we know, over 90% of people who report an antibiotic allergy aren't truly allergic. And if someone reports they have a medication allergy, it can force prescribers to give antibiotics that have a higher risk of side effects, including the development of a C. diff infection. When you think of infection, there are 3 phases. We start with the person who has a C. diff spore in their intestine. There is a disruption in the normal flora of the gut, which allows the C. diff to germinate and grow. Then the release of toxins damage the bowel wall and the body's immune system reacts, leading to the symptoms of a C. diff infection. After treatment, there is a window of vulnerability, which is the time between the end of the antibiotic course to treat the C. diff and the gut flora getting back to baseline. The symptoms of C. diff can vary. So from a few episodes of diarrhea and very mild symptoms to very frequent diarrhea, up to 40 times per day. All patients with a C. diff infection will have diarrhea, and many will also have fever, belly pain, nausea, and loss of appetite. There are levels of severity. For those with the mild to moderate severity, they typically have a white count of less than 15,000 and a serum creatinine level of less than 1.5. For those with severe infection, additional symptoms may include abdominal distension, hypovolemia or dehydration, lactic acidosis, and low albumin. In those cases, the white count will be elevated, sometimes markedly so, up to 30 or 40,000, and the creatinine will also be elevated. Fulminant infection is the most life-threatening. In these cases, patients may develop ileus, shock or sepsis, and multi-system organ failure. There are also risks of developing toxic megacolon, perforation of the intestines, or pseudomembranous colitis. There are a variety of lab tests for C. difficile. Some tests are able to identify the presence of C. diff and some identify toxins. As you'd expect, the price and accuracy of these tests vary. Some are very accurate, but take a long time to get results, for example. It's important to remember that not all C. diff bacteria cause illness. So just identifying the presence of C. diff will lead to overdiagnosis and overtreatment. The cell cytotoxicity neutralization assay and toxigenic culture have been considered the gold standard, but not many labs have the equipment to carry out those tests. Those tests are also labor-intensive and can take 2 or more days to result. The enzyme immunoassay test is quick and not too expensive, but it's also labor-intensive and doesn't have a very good sensitivity, requiring at least 3 separate stool samples. Most labs use a 2-step algorithm that will help identify the presence of C. diff and determine whether it is toxigenic or producing toxins. The first algorithm is the immunochromatographic assay with a GDH, and then follow up with a PCR if the results are ambiguous. And second, a PCR for the toxin gene, and then if it's positive, follow up with an EIA. It's also important to note that any stool samples must be liquid, and if they are not able to be tested within 2 hours of collection, they need to be refrigerated. As with any sort of diarrheal illness, it's important the patient stay hydrated. If the GI losses are severe or the patient isn't able to drink enough, IV hydration is needed. For those with significant diarrhea, electrolytes may need to be monitored and repleted as necessary. If the patient's able to eat, we would encourage a normal intake as tolerated. Treatment of the infection consists of an antibiotic treatment for 10 days. As I mentioned earlier, 1 out of 6 people will get another C. diff infection. And for subsequent infections, treatment usually consists of a prolonged antibiotic course that slowly tapers. Patients may also receive a one-time dose of IV monoclonal antibodies. For patients with 3 or more infections, fecal transplant may be warranted. Fecal transplants allow doctors to place healthy stool from a donor into the patient's intestine. This can be done once, but receiving several doses over a period of days appears to be more effective at curing the C. diff infection and preventing further episodes. For the patients with severe or fulminant cases, surgery may be required. Right now, there's not enough good evidence to recommend the use of probiotics to prevent or treat C. diff infections. It's also not recommended that patients receive any sort of prophylactic antibiotic to prevent an initial case of C. diff infection. However, for those with a history of C. diff infection who are taking an antibiotic for another ailment, they can be given a low dose vancomycin once daily, during the course of that antibiotic therapy and for up to 1 week after the completion of the antibiotic course. As healthcare staff, how do we prevent the spread of the C. diff infection? Well, we must be quick to identify patients who have a C. diff infection or those we suspect might have an infection and isolate those patients. We should be using contact isolation until we have confirmation the patient doesn't have a C. diff infection. We need to make sure we notify the physician or APP so the patient can be evaluated. In the ideal situation, these patients will be placed in a single room with a dedicated bathroom. If that's not possible, cohort confirmed cases. When possible, use dedicated patient care equipment such as blood pressure cuffs or stethoscopes. Encourage daily bathing or showering with soap and water. In the event the patient is transferred or discharged to another facility, be sure to notify the new unit or facility about the patient's diagnosis. It's also important that we develop the infrastructure to support C. diff infection prevention. This can include educating and training staff on C. diff infection prevention practices, auditing hand hygiene and contact precautions, monitoring the rates at your facility. If you find that a particular unit or area has a higher incidence of C. diff infections, you can focus on that area to determine if there are any gaps in care or education. It's also important to disclose rates of infection and any performance improvement measures to all stakeholders, including the clinical staff, environmental service personnel, and lab personnel. A quick note about hand hygiene. While alcohol-based hand sanitizers are appropriate in most cases, spores are not affected at all by alcohol. You must use soap and water to clean your hands after caring for a patient with C. diff infection. Make sure that you're scrubbing thoroughly and get the nails, the backs of your hands, thumbs, and between your fingers. Scrubbing with soap will lift the spores up off the skin so they can be washed away with the water. Make sure you're washing your hands not only after caring for patients with C. diff infections, but for any diarrheal illness. You also clean your hands after using the restroom and before eating or preparing food for yourself or others. And then, of course, a word about PPE. Most of us are familiar with appropriate PPE, but I do want to take a moment to review. Standard precautions are used with all patients, and we choose our PPE based on the type of potential exposure. Enhanced barrier precautions are used for patients with multi-drug resistant organisms or indwelling devices. Gown and gloves are used during high-contact patient care, such as bathing, assisting with hygiene, and caring for devices or wounds. Eye protection can also be used if there's a risk of splashing. Contact precautions can be used for many reasons, but are always used when caring for patients with acute diarrhea or C. difficile infections. For those patients, gown and gloves are donned prior to entering the patient's room for any reason. Many of us are familiar with the concept of antibiotic or antimicrobial stewardship. The ultimate goal of antimicrobial stewardship is to prevent antibiotic resistance, and this is done by optimizing antibiotic use, reducing the use of unnecessary antibiotics, and decreasing the use of those antibiotics associated with a higher risk of harm. They tend to say they want to do the right antibiotic for the right patient via the right route for the right length of time. In order to decrease C. diff infections, it's important that we not give unnecessary antibiotics because we know that will disrupt the gut biome and increase the risk of developing a C. diff infection. Likewise, we don't want to test unnecessarily. For patients with new onset clinically significant diarrhea, we also want to look at the frequency and the consistency of the stool. The patient should have 3 or more stools in a 24-hour period, and the stool should be very loose or liquid, 5 to 7 on the Bristol stool scale. We should also rule out other causes of diarrhea. Things that can cause diarrhea include the use of laxatives or stool softeners, enteral feedings, chemotherapy, chronic bowel disease, and the use of immunosuppressants. Other diagnostic considerations include not testing for C. diff infection based on the smell or color of stool. Many experienced staff will report that stool smells of C. diff infection, but studies have found that smell alone is not sensitive enough to warrant testing. We should not be testing for a cure, and we don't want to retest someone for C. diff within 7 days. For patients, it's important that you tell your doctor about any previous C. diff infections, and you only take antibiotics that have been prescribed for you that you have discussed with your doctor. For those that have symptoms of C. diff but do not require hospitalization, be sure to encourage hand hygiene with soap and water, especially after using the restroom or before eating or handling food. If possible, they should be using a separate bathroom from other family members. They should not be going to work or school while having diarrhea unless this have been approved by their physician. And again, stress the importance of daily bathing or showering with soap and water. We note that if a patient is placed in a room where the previous occupant had a C. diff infection, this patient's chance of developing C. diff is increased. This emphasizes how important environmental cleaning is. C. diff spores can live for months in the environment, and most of the cleaners that we use in healthcare facilities aren't sporicidal, meaning they have no effect on the C. diff spores that can be on surfaces. Only chlorine-based products and vaporized hydrogen peroxide can kill spores. Patient care areas and equipment should be cleaned daily with appropriate disinfectant. Patients with CDI should have their room cleaned daily with a sporicidal agent, which will be listed on the EPA's K list. The focus should be on the immediate vicinity around the patient and high-touch surfaces, including toilets. Make sure that you know the contact time of the product that you use. Terminal cleaning should be performed after the patient is discharged or transferred. Any shared equipment needs to be cleaned and disinfected before being used on another patient. And any areas visited by the patient with a C. diff infection should also be cleaned properly. And those examples would be patients that need to go to radiology or physical therapy. This is a screenshot of the EPA's K list. You can see that it lists the product names and ingredients. It's also important to look at the formulation type to determine if this is ready to use or must be diluted, and to note the contact time needed to kill spores. This label is from a canister of ready-to-use wipes. It's hard to see due to the size, but the label lists the active ingredients at the top. Near the bottom left, it states sporicidal performance against C. diff spores and goes on to note the contact time is 2 minutes. The label also contains other important information, such as environmental hazards, directions for use, and first aid in case of contact. There are also some products that can be used in addition to environmental cleaning. Please note, these do not take the place of environmental cleaning. These just can be used in addition. UV light robots provide high-intensity radiation and are able to break the molecular bonds to destroy C. diff spores. Ultrasonic machines aerosolize hydrogen peroxide and acetic acid to destroy C. diff spores. And UV ceiling mounted disinfection systems use differential pressure to isolate contaminants, which are then destroyed in a UV radiation chamber. These vary in cost, but they do tend to be expensive. However, they do appear to be very effective at further disinfecting environments. That is all I have today. Please reach out to me with any questions or further clarification. Thank you so much for joining me in this overview of C. difficile infections.
All right. Well, as I said, I'm pre-recording it, so don't bother with sending us Q&A. But just wanted to say, hope you enjoyed that. Be sure to go to our website. You'll be able to get the link to get the credits. All you do is click the box that brings you there, and then you fill out a few things, and you'll be able to get the credits. Pretty easy to get. I think you guys are getting the hang of it now because we've done a few of these. And I did want to have a little plug for next week's show.
Paresis, also known as shy bladder syndrome, is more common than you might think and can deeply affect patients' lives. In this eye-opening episode, Dan Rocker, LCSW, breaks down 5.5 crucial insights every urology professional and patient should understand about this often misunderstood condition. Learn how to recognize the signs of paresis in your patients, understand the psychological underpinnings, offer compassionate and effective support, explore therapy options that work. Join us May 31st at 9 a.m. Central Time on UroNurse.com.
Yeah, so join us next week for that episode. Interesting story. I did talk on periuresis for my Uro Patient podcast because I had a patient write in about they were going through some test. I think it was AccuCuff, and they were worried about not being able to go to the bathroom because they suffered from shy bladder syndrome. So I decided, well, I'll do an episode about that, kind of inform people about the disease. And Dan Roker, who's going to be speaking on this, is actually the president of the International Association for Periuresis. And he wrote in after the program and said, hey, he really liked it. Just kind of wanted to compliment me for putting that out there. And I said, wait a second, you're the president? I said, I need to get you on UroNurse to talk about this subject. So next week, join us and we'll have a great subject for you. Otherwise, enjoy the rest of your day and go Fever.